Hello, hi dear my friends. My name is Dr. Praveen Kr Gupta, and in this video, we'll discuss the 10 main important questions that may be coming in the recent exams. Do not look at the questions only, look at my discussions and look at the important points. I'm pointing it out right now so that you get a fair amount of idea that what are the important questions that may be asked from in and around this topic. Let's start it. Read the question. The question says, a 60-year-old male with complaints of hematuria and mild facial puffiness. Okay. Occasional hemoptysis. The combined feature that you see here is of edema. There is a hemoptysis. That means there's a lung and the kidney both getting involved. And the direct immunofluorescence, DIF is direct immunofluorescence. Picture is shown below. Now, what do you see here is, if you look at this image, this basically is a glomerulus. Okay. And look at these very smooth, shiny GBM getting outshined, getting shined because of the antibody against them. That means in this image, you can look at the immunofluorescence, and the fluorescence has been done with the anti-GBM antibody, which is giving the such type of smooth linear deposits. Well, linear deposits in a case of a diff in a kidney is often seen in a Goodpasture syndrome. Now, the following is not true about the given condition. So, it is proven by the condition of edema, which can be seen in nephritic syndrome, and as well with this is the involvement of lung. Now, if you look at the choices, so because we're discussing this as a choice of a Goodpasture syndrome. So guys, what do you know about it? You all know it is an anti-GBM antibody disease. You know this antibody is against the collagen 4 alpha 3, okay, collagen 4 alpha 3 of the non-collagenous end. So that makes option A true. Well, it is seen with HLA DRB1, that also is very much true here. Okay, crystals are seen in 50%. Remember, the most common finding of the Goodpasture is RPGN. Yes, I'm not saying that the most common cause of RPGN is Goodpasture. What I'm saying is the most common presenting type of Goodpasture is RPGN, and mostly, as you remember, it's RPGN type 1. Well, dense deposit seen. See, why don't you get a dense deposit? Please understand this point. You don't get a dense deposit because it's a linear deposit. Linear means you don't get dense, you get a linear deposition. Now, linear means you get only antibody. But if you see a dense deposit, the dense deposit is seen with antigen, antibody, matlab immune complexes. Yes. So if you find a circulating immune complex and that getting depositing in the kidney, you call it dense deposit. But this one is only an antibody deposition. Remember, it's a type 2 high percent reaction, not a type 3. So a disease like a PSGN or a MGN, MPGN, IgA nephropathy, those may show you the dense deposit disease along with SLE. These all diseases can show you those. Remember, RPGN is of 3 types. I hope you all remember. The RPGN is of 3 types. RPGN 1, 2 and 3. RPGN type 1 is a linear deposit, right? RPGN type 2 is a granular deposit, and RPGN type 3 is a Posse immune deposits. It's a Posse immune deposits. Linear deposit is an anti-GBM antibody. It's an anti-GBM antibody deposits. Posse is of 3 types. Remember the Church-Strauss syndrome, vaginous Adenomatous, and microscopic polyangiitis. In granular, that is the type 2, you find a lot number of diseases, and like it can be MPGN, it can be MGN, it can be IgA nephropathy, it can be Henoch-Schönlein purpura, it can be, in rare cases, it can be PSGN, even the 1% case can be a case of PSGN also. It can be infections, so infective conditions, all of those will also go under granular deposits. Remember, the type 1 is linear in the diff, type 2 is granular in a diff, and type 3 shows no finding in the direct immunofluorescence. All these RPGN findings shows what? They show, yes, a flea-bitten kidney, and they show a rupture of the GBM in the electron microscopy. Okay, so ensure that you revise this chapter and this topic especially very well. Question 2. A 24-year-old lady, she has a painless left side breast lump for last 2 months. Okay. Local examination revealed a soft mobile non-tender mass. Well, soft mobile non-tender mass in a breast. You don't need to look at the image also. But if you look at this image and understand what is this, let's label it Guys, देखो, this pink area is all the stroma. Okay, these are all the lobules. Okay, they're all the lobules. Now, what you're seeing in the disease is the stroma has increased and so has the lobules. The stroma has increased and so has the lobules. Now, with this history in mind, what you understand is, see, it is a case of fibroadenoma. Now, why not phylloids? Because if this would have been phylloids, you would have seen a lot, huge amount of stroma, and these tubules, or you can say these, alveoli, these all might have got reduced to very, very fine area. You might have not been able to see. Secondly, in phylloids, the celerity in this stroma would be more compared to a fibroadenoma. Now, why is not invasive carcinoma of the breast? Because there's no infiltration of these tumor cells in the stroma, and hence is not invasive carcinoma too. So you can quickly rule out. So we're looking at the history. A faint, mobile, non-tender mass should be nothing but a case of fibroadenoma of the breast. A 45-year-old patient presented with features of hypothyroidism. So this is a hypothyroidism feature for 2 to 3 years. And histopathology has been done ultimately to find out the features. So see, this area looks quite like a normal area of the thyroid gland. But what you see in the other area, like in this area, like in this area, or this area, do you see, if you notice, they do not look at the thyroid gland at all. What they look like is actually it looks like a lymph node. So what it says, a Jamana center, and you see these are all the lymphocytes, right? Like a lymph node. And what you also see here are these are pink areas. This pink area are actually what the Hurthal cell change. Well, three things you find here. Number one is a lymphocyte. Number two is Jamana center, and number three is the Hurthal cell change. With these three things in mind, with a feature of hypothyroidism in the patient's clinical features, it may be a case of Hashimoto thyroiditis. Why not granulomatous? Because you don't see any granuloma in the image. The granuloma should be there in the granulomatous. Why not papillary carcinoma? Because here you should see an orphan Annie nuclei. And why not riddles? Because this will show you nothing but fibrosis and may show you an increase in the IgG4 in the serum. May, not always. So I'm writing it plus minus, that it can often be seen in thyroiditis. Remember, in Hashimoto, what happens is initially because of the destruction of the gland, you see increase in the T3 and T4 initially, but later on you see reduction in the T3 and T4 levels. Initially increase, and then you find decrease in the T3 and the T4 levels. Okay. A 45-year-old patient presented with history of hypertension, excessive sweating, and palpitations. Okay, and palpitations. Patient is a chronic hypertensive, and CT scan shows a patient in the adrenal. Lesion is in the adrenal. So what you see here is, if you look at here, a patient has a hypertensive history and there is sympathetic stimulation. Please understand, there's a hypertension along with a sympathetic overactivity, which can be seen in a case of increase in the catecholamines. Well, increase in catecholamine with a lesion in the adrenal. So adrenal will have two areas, adrenal cortex and adrenal medulla. As you all know, adrenal cortex has three areas, GFR, yes, glomerulosa, then there's fasciculata and the reticularis, releasing the MGS, mineralocorticoids, glucocorticoids, and sex steroids. So, if you look at these all things, the tumor can be either of the adrenal cortex or can be of adrenal medulla, which releases the catecholamines like sympathetic stimulation releasing epinephrine and norepinephrine. Well, these findings will occur mostly with the epinephrine and the norepinephrine being increased. And therefore, you can say it's an adrenal medullary tumor. So when you say adrenal medullary tumor, the two types of tumor you can come across through. In an adrenal medulla, a tumor can be of sympathetic ganglions, which can be, it can be a neuroblastoma, or it can be a tumor of the catecholamine, which can be a case of Pheochromocytoma. Now you see, look at the histology. The histology is showing you the tumor nests. Okay, these nests are called as Zell-Ballen pattern. Zell-Ballen pattern. Well, all these nests have what? They have the catecholamine releasing the tumor cells. And around the nest here, it is not very clear though in this image, but you'll see these cells called as sustentacular cells. They're called as sustentacular. Okay, they're referred to as sustentacular cells. These cells stain positive with S100. Okay, these cells they stain positive with the S100. Okay, the positive stain with S100 is often positive here, SUSTE, okay, tentacular cells. Now, they're S100 positive. Therefore, this case becomes a case of Pheochromocytoma. Well, if this would have been a carcinoid will also have been showing you similar nest. But what you don't see in carcinoid are this typical feature of sympathetic overstimulation. What you get initially is the feature of hypotension, right? Because of the release of serotonin, you get vasodilation, you see hypotension, you see flushing, and you see diarrhea. Why it is not neuroblastoma? Because neuroblastoma will show you what? A small round tumor cells along with homocyte rosettes. Okay, and ganglioma will show you ganglion as a tumor cells there. Okay. Next question. A 20-year-old patient presents with a clinic with a history of malabsorption, diarrhea, and poor appetite. The vomiting and poor appetite is again being seen here. And biopsy shows a crypt hyperplasia. Look at the crypt here. Let me draw this with in yellow color. These are crypts. The crypt hyperplasia is there. All the round things are all crypts, right? The all round things are crypts. Okay. Now, villus atrophy. Look at these are the normal villi. On the left side, you see the normal villi. It's normal villi on the left side. Villi on the left side, right? And what you see is absence of the villi here. You see absence of villi here. So we can say villus atrophy. You can see CD8 cells being seen here. You see a CD8 T cells being seen in this area. So what do you expect here to be? Yeah, you expect here to be nothing but a celiac disease. With the infiltration of CD8 cells, you see loss of villi, or you can say villus atrophy. You can see crypt hyperplasia. These all are feature of villus atrophy in a case of a celiac disease. The other thing you should know is a celiac disease is basically a hypersensitivity to gluten containing foods. Gluten containing foods are what? They are barley, yeah, rye, oat, and wheat. You should also know they are seen in the patient who have typical HLA DQ2, DQ8, and HLA-B8. You should also know the antibodies. 3 antibodies are very important here. They are IgA type of anti-endomysial antibody, IgA type of anti-endomysial, not endomysial, okay, this endomysial antibody, IgA type of anti-TTG antibody, and IgA type of anti-gliadin antibody. The treatment is avoid the gluten in the foods. That is the best way of treating a case of celiac disease. So it is a case of celiac disease. Why not environmental enteropathy? Because this is due to infections. Infections is often the etiology, which can be E. coli or can be Giardia. Why not Whipple's? Because Whipple's will show you past positive disease. And why not a chronic pancreatitis? Because chronic pancreatitis will show you a fibrosis in the pancreas, not in the intestine at all. A 42-year-old male patient with vague abdominal complaints, okay, who underwent as found to have multiple colorectal polyps. Prophylactic proctocorectomy was done and ileostomy was ultimately performed. Okay, 2 of his children was evaluated and found to have a multiple colorectal polyps on colonoscopy. What you see is colonoscopy is, look at this huge number of polyps you see, which is obviously more than 100 in number. In the biopsy, look, these are the normal area of the glands, but look at this area. These all are the dysplastic. Look at the huge pleomorphic, hyperchromatic, and high NC ratio cells around the gland. Compare this gland with the upper gland. It's normal gland. And look at this gland, quite dark in color, the cells showing you hyperchromatism, pleomorphism, and all the findings you see in a dysplasia type of gland. So this is surely a case of an inherited polyps, and because the father and son both have the history, you can say it to be an autosomal dominant inheritance pattern. With the more than 100 polyps, diagnosis becomes a case of familial Adenomatous polypi. But this has been proved by a APC gene mutation. Unless you don't see an APC gene loss, you will not be able to tell whether it's a case of PAP or not. Number of polyps should be more than 100. Well, a few things about PAP. It's an autosomal dominant disease. Well, it has extra intestinal manifestations, which is obviously seen in a case of multiple tumors of the other sites as well. And 2 syndromes you should always remember: Gardner syndrome with supernumerary teeth, and you see the osteomas of the bone, and you see what is called as desmoid tumor. In other syndrome called as Charcot syndrome, you see the brain tumors like the glioblastoma and the medulloblastomas. With this thing in mind, look at the first option. It is autosomal dominant, so first becomes false. Polyp is seen. Yes, that's true. More than 100 polyp is confirmatory is very, very important. And when you see more than 100, do a biopsy. If you see a case of this dysplasia in the biopsy, go for prophylactic colectomy in the patient. And external manifestation is definitely false. Why? Because it surely has Charcot syndrome. It has the Charcot syndrome and Gardner syndrome, and along with that, it also has increased risk of the tumor at other sites like the hepatobiliary system tumors. There is a brain tumor, there is a breast tumor, there is an ovarian tumor that also increase in a case of familial adenomatous polyp. So it is false, false, true, and true. Answer becomes C. Next question. All the following statements are true regarding the histological features of rheumatic heart disease, except is the main finding, except. So see, in rheumatic heart disease is all about vegetations. So I'll just tell you about the 4 vegetation you should know. First of all, let's understand the acute rheumatic heart disease findings. So acute rheumatic heart disease has what? It has pancarditis. I'll just differentiate them into 3 types of carditis. It can be pericarditis, it can be myocarditis, it can be endocarditis. In a pericarditis, you see bread and butter. Pericarditis. In myocarditis, it shows action of bodies. In endocarditis, it shows vegetations. And you also see in left atrium. Remember, in left atrium, it shows a very important finding, and that finding is called as the McCollum's patch. McCollum's patch. Well, among them, know about vegetation in detail. What happens in mitral valve? In mitral valve, suppose there's a mitral valve, you see the vegetations along the lines of closure like this. Along the lines of closure like this. And this causes this whole thing to initially cause mitral regurgitation, not mitral stenosis. Initially cause mitral regurgitation. Okay. Then, as it becomes chronic, now, as the disease becomes a chronic rheumatic carditis, the same valve, it becomes more and more fibrotic and calcified. And now the opening, it looks like a fish mouth, like this. The ends are fused, and now you see the opening like a fish mouth, and hence the name is fish mouth apparence. Okay, at this time the walls are fibrous and calcified, and the commissure, that means the ends are fused there, and this is the finding of acute and chronic rheumatic carditis. Okay, look at the disease. Usually we see ashen body, and mostly they are seen in any 3 level of heart, but are most commonly seen in the myocarditis, but can be seen in any of the 3 layers. Subendocardial lesions, that is McCollum's patch, are seen in the right. No, they're seen in the left atrium. And why does it happen? Because mitral valve are in the left side, left. So as the ventricles contract, the blood will regurgitate back at left atrium, causing this type of hitting the left atrial wall again and again, causing the fibrosis of that area of the wall. Leaf thickening and commissure fusion are seen. That's very true. I showed you this image also here. And shortening, and thickening and fusion of the tennis cord are often seen. That means this cord here, these are tennis cord like this, which will hold the vital valve. Now these all can be fused together like this. They're going to be fused together like this. And hence we see thickening, fusion of the valves. Okay. So answer is B. 8th, autopsy of a person who died of a severe respiratory distress following a COVID-19 infection shows the following. Well, what you see here is this, you see alveoli, and look at the arrow marked area. This all arrow marked area you see here, they all are what? They are halines. Okay, they're all halines. You see this disease can to be a hyaline membrane disease. You see this to be hyaline membrane disease, HMD. Okay. Now, in a hyaline membrane disease, what you see is the endothelial activation is the first proper event. So, what you see in ARDS? Yes, you can't call this ARDS. If I show you in short what happens in the COVID-19 infection, especially in the case of alveoli, see, this is the alveoli, and this is the blood vessels. Okay. Now, the etiology, they all start damaging this type 1 pneumocytes. Let's say the type 1 pneumocytes have got damaged now. The type 1 pneumocytes have got damaged. This is normal type 1 pneumocytes with this nucleus in the area, and type 1 in this area has got damaged. Why? Because of etiology. Remember, the vessels of this endothelium also start getting damaged. So I can say the vessels here has getting damaged. So endothelial activation is followed by endothelial injury. Because of the injury, first of all, you should know there's a microclot formation here. And this is the reason why the D-dimer level increases in the COVID-19 infection. The microclots here. And along with this, the blood, you can say the fluid and the fibrin, they leak out into this area. So when the fibrin and the water leaks out of this area, the fibrin starts depositing here like this acid. The fibrin starts depositing this area like this acid. This whole fibrin deposition is referred to as hyaline membrane deposition. This whole thing is referred to as a hyaline membrane deposition. Hyaline membrane deposition. Well, hyaline membrane deposition is of type 1 and type 2 pneumocytes. They show type 1 and the type 2 pneumocyte damage along with the fibrin that is mixed out with the damaged endothelium. This is deposition of hyaline and hence the name is HMD. These are microclots here. There's a microclots here. Microclots you see here, and that is the reason why it shows a raised D-dimer levels. Okay, raised dimer levels. Now, if you divide the entire event into three parts, the first event is about the exudation, destruction. The second event is about proliferation of the type 2 pneumocytes, which will relay the type 1 pneumocytes. And the third event will be fibrosis. So if you look at the events one by one, the first event will be destruction. First event will be destruction. Second event will be proliferation, destruction, proliferation of which cells? Proliferation of type 2 cells, not of type 1 but type 2 cells. And third event would be fibrosis. Destruction is referred to as exudation stage. So the three stages of the disease called as ARDS like finding. ARDS like finding. So if you look at the question now, the answer becomes very simple. See, a neutrophil in this area will ultimately exudate and will come into this area. So neutrophil will migrate from the endothelium into the alveoli. Remember, neutrophil will migrate from the endothelium into the alveoli, and hence this finding is very, very important, guys. Okay, neutrophil is very, very important to move there, and therefore this neutrophil starts to damage. It will damage this whole area. Neutrophil damages the entire area, and that causes the pathophysiology of ARDS to move ahead. Look at this area. So yes, you see endothelial activation, you see hyaline membranes too, you see edema neutrophils, but neutrophils, they do not migrate to the endothelium, they migrate to alveoli. So answer is D, which is not a true statement here. Okay. Remember, this is also what you see is a ground glass appearance, and this is hence called as hyaline membrane disease. Next question. A 6-year-old child has a pallor that requires a 2 blood transfusion previously. That means he has severe amount of anemia. He has fever and hemorrhage also. Now he has anemia, he has fever, and also has thrombocytopenia, which may be the cause of hemorrhage. His hemoglobin is 9 now, and platelet count is 20,000. A TLC of 60,000 is seen. A flow reveals CD10 to be positive, MPO to be positive, 19 to be positive, and 33 is negative. 117 is positive and C3 is also negative. Now what you see here, guys, is two findings. Number one, you should notice the findings are about MPO being positive and hence it's a myeloid tumor, but 19 is also positive and hence it becomes B-cell tumor. Such cases are referred to a case of mixed phenotypic leukemia. Well, I understand you always get confused between tumors like mixed phenotypic and biphenotypic. What are these? A mixed phenotypic acute leukemia is a condition where you see two specific, please understand, two specific lineage markers in two different cells. Biphenotypic means two specific lineage marker in a single cell. It becomes a biphenotypic leukemia. So mixed phenotypic leukemia is like a myeloid marker and a B-cell marker in a same patient. But biphenotypic means a same cell has myeloid marker also and a B-cell marker also. Remember, a cancer can have anything. Anything is possible in cancer, and therefore these type of finding often occurs there. Well, remember one thing, it should be a specific CD marker. For example, for the myeloid, it should be MPO. For B, it should be 19. For T, it should be 3. Only then you call this a mixed phenotypic or a biphenotypic acute leukemias. Okay. Question 10. A 15-year-old female presents in the OBS clinic with complaints of heavy and long menstrual bleeding, blood clots in her menstrual flow. Now, on taking further history, she revealed that she used to have double sanitary protection and chain it very often. That means she has a history quite often from the previous times. Well, she reveals that there have been episodes of easy bruising and nosebleeds as a child. You order for the blood test, and what you get here is blood green time is prolonged, ABT is prolonged, PT is normal, tourniquet test is positive. That means she has thrombocytopenia also, and you see a clotting time also getting prolonged. Well, what you get here is, look at the choices. ITP. The ITP will never have a APT prolonged. It can't be that. Similarly, hemophilia A and hemophilia B will never have a brain time prolonged because these two are the finding of factor 8 deficiency. So, availability will have a brain time prolonged because of the problem in the platelet primary plaque formation, will have a tourniquet test positive again because of primary plaque formation defect, and will also have a factor 8 deficiency. Why deficiency? This is due to a VWF deficiency. So because of the VWF deficiency, these patients will have factor 8 deficiency, and that's the reason they will have increase in the APTT, and hence the answer becoming von Willebrand disease. Remember, VWD is of three types: type 1, type 2, type 3, where the type 1 is autosomal. Type 1 is autosomal dominant, type 2 is autosomal dominant, type 3 is autosomal recessive. Type 1 has mild deficiency, type 2 has a qualitative defect, and type 3 has a severe deficiency of the von Willebrand factor, and hence that disease is autosomal recessive in nature. Well, also you must remember that how to differentiate the factor 8 deficiency along with VWF deficiency. See, what happens often is, if you look at this whole story, factor 8, this belongs to the intrinsic pathway. Because it belongs to the intrinsic pathway, what you expect is increase in APTT. Factor 9, it belongs to which pathway? It belongs to the intrinsic pathway. So we'll also have increase in APTT. Well, this is called as hemophilia A. It is called as hemophilia B. If you look at the VWD, it will have VWF deficiency. Now remember, a VWF has two functions. Number one, a platelet addition, more than aggregation. And second function it also has, it stabilizes the factor 8. Because it stabilizes factor 8, you must notice one thing. Because it stabilizes factor 8, therefore it will have increase in the APTT also. And because these defects, they'll have what? They'll have thrombocytopenia, they'll have a tourniquet test positive, and they will have a green time also getting prolonged. And hence the answer to this question will become VWD. Well, one more finding that can confuse you here is often called as APLA. In APLA, what happens? APLA, the antibody is against beta-2 GPI. Antibody is against beta-2 GPI. Because the anti-beta-2 GPI antibody, what happens? This antibody is against phospholipid. And so all the phospholipid based tests are prolonged. It will show you increase in the APTT. But remember, such cases are asymptomatic. But they present as recurrent pregnancy loss. Or they may show you a history of preterm delivery. So with these two history in mind, you can think about APLA, and APLA will also show you an increase in the APTT. It can also show an increase in the APTT. So finding that you often see in APLA is thrombocytopenia, increase in the APTT, and the antibody you see positive is anti-beta-2 GPI, and can also show you anti-cardiolipin antibody, anti-cardiolipin antibodies. These are all findings you expect in what is called as anti-phospholipid antibody syndrome, called as APLA. So with this history, you can differentiate the disease. So always first understand to differentiate a PT and the APT. Remember the intrinsic and the extrinsic pathway, and then look at the common pathway you expect there. Remember, if the question is on intrinsic extrinsic pathway, it becomes very simple. Intrinsic pathway and extrinsic pathway, very simple. Remember, see, draw a common pathway first. Common pathway matlab factor 10. And 10 ka half 5, 5 ka half 2, and 2 ka half 1. This is how the common pathway moves forward. In the extrinsic pathway, there is only one factor, factor 7. In intrinsic pathway, it starts from 12, 12 activating 11, 11 activating 9, and 9 activating ultimately 10 with the help of 8. So just make the thing simple and don't complicate yourself. You all know this is measured by a PT and this is measured by APTT. So intrinsic pathway and common pathway is APT. Extrinsic pathway plus a common pathway is measured by a PT. Very simple to remember. Short name, short pathway, long name, and the long pathway. A simple rule how to diagnose these cases. Well, thanks a lot for your valuable time. I hope you like this video, and if you liked it, do share and subscribe to the channel, and also ensure that you get this PDF from my Telegram group. It's quite available there, and make sure you make the best of your time ever available there. Do not get demotivated. Always have that motivation. You can do well, and in case of any doubt, feel free to ask me that you have, and I'll ensure that it is solved at that moment only. With that wishes, Dr. Praveen signing off. Take care, goodbye, and stay in good health.